Okay, good morning, students. Today we are just going to go through some questions, and this class today is very, very useful for you as a clinician. Like later on, you will find these are the things which you have to deal with. So it may not be the actual, some of them are actual questions for pathology, analytical questions, which I will be telling you. And some of them, when I go through it, I will just give you an inkling of how you're going to investigate further, okay, which is extremely important for you in your later on practice. So looking at the first question, this is a 16-year-old girl, okay? So when you look at a question, it is very important for you to look at the age and the sex. Then the next is hemoglobin is 10 grams per deciliter. So you have to know what is the normal hemoglobin in a 16-year-old girl. You expect it to be definitely above 12. So you know that this girl has got anemia, okay? WBC is 8,000 per cubic millimeter. So looking at the normal WBC count, 4,000 to 11,000, so 8,000 is okay. You feel there's no problem in this. Differential count, neutrophils are 70, lymphocytes are 25, eosinophils are 5. This also seems okay. Platelets are 2 lakhs. This also seems all right. But the mean corpuscular volume is 65 femtoliters. So looking at this, you know that it's a young girl. Hemoglobin is low, that means she's got anemia. And looking at the MCV, which is low, you know that it's a microcytic anemia. So it's such a question, when you think, you have to think about the probable causes of microcytic anemia in a 16-year-old girl. It will be the most common is the iron deficiency anemia. Okay. I just want to make one point here, which I have not added here because we are basically discussing WBC disorders, but this question is more of an RBC disorder. So here, when you get an MCV which is extremely low and the hemoglobin which is around 10, you have to also look at the RBC count, which I have not given here. If the RBC count is towards the lower level, you can think of a microcytic hypochromic, probably iron deficiency anemia. But if the RBC count seems like above, like high normal, okay, maybe 4.5 million or something, despite the RBC count being low, being high, normal or high, and the hemoglobin being low and the MCV being low, in those cases you have to suspect an underlying thalassemia trait. Okay, so a 16-year-old girl with a low hemoglobin, very low MCV, and RBC count which is normal or slightly high, you have to think of a thalassemic trait. Whereas a 16-year-old girl with a hemoglobin which is low, MCV which is correspondingly low, and RBC count which is in the lower side of normal, you should think of an iron deficiency anemia. Okay, so that is very important in your practice. Second is a 16-year-old girl, hemoglobin is 12 grams, so it seems okay for her age. 10,000 WBC again seems all right. The DLC neutrophil is 92, lymphocyte 4, monocyte 2, eosinophils 2. Platelets 1.8 lakhs, which again seems all right. MCV is 80 femtoliters, which again seems normal. Okay, so what is the information we are getting here? The only abnormality we are getting here is the differential count. That is, the neutrophils are too high, right? 92% means this is too high. So when you look at this, the WBC count is still within normal, the total count is still within normal, but the differential count neutrophils are very, very high. So this condition is neutrophilia, okay? And clinically, you have to look for signs of infection. If she's got fever, you have to investigate along lines of the infection, okay, to explain the neutrophilia. The next question, 16-year-old boy, hemoglobin is okay for a boy, 14 grams, WBC 18,000. This is high, okay? So when you look at the WBC, which is high, this is a proliferative state, okay? Then if you look at the differentials, you're finding again, neutrophil is 92% and the others are lymphocyte, monocyte and eosinophils, which are normal. So again, here you're getting neutrophils which are very high and the WBC count is also high. Note the difference between question number 2 and question number 3. The only difference between these two is the total count. Okay, so in this case, the total count is normal, neutrophils are high, so it is neutrophilia. If the total count is high, it is leukocytosis, and there is neutrophilia as well. So this is a combination which is known as neutrophilic leukocytosis. Okay, so I hope you're following till now. Coming to the next one, it's a 2-year-old child. Hemoglobin is 12 grams. WBC is 10,000. Neutrophil is 34. Lymphocyte is 52. Eosinophils are 14%. Platelets are 2.5 lakhs. So if you look at this, you have to know what is the normal count in a 2-year-old child. A 2-year-old child is almost like a adolescent only. Okay, the counts don't vary so much. So hemoglobin 12, we would say for a 2-year-old child, hemoglobin 12 is in the lower side of normal. Okay, but still within normal. WBC 10,000 is within normal because WBC in a 2-year-old child can go up to 18,000. If I had put 2-year-old 18,000, it would have still been within normal. Okay. After that only the total count comes down to adult values, 4,000 to 11,000. So in this case, WBC being 10,000 is still within normal. The differential count is very important. As you can see here, neutrophils are 34, lymphocytes are 52, and eosinophils are 14. So eosinophils, you know, the normal eosinophils are around 4 to 8. So 14 is high, so this is eosinophilia. Now, if you look at lymphocytes, this is 52%. Is this high? You have to look at the age. If it's a child, lymphocytes 52% is normal, okay? And neutrophils 34% is normal. Platelets 2.5 lakhs is normal. So in this case, the only finding you're getting here is eosinophilia. And if you get such a case in medicine, you're getting eosinophilia in a child, deworming is the next thing you have to do. Stool examination, look for ovocyst and deworming or antihelminthics. Okay? Coming to number 5, we have a 25-year-old lady with acute cholecystitis. Her hemoglobin seems okay, 12. WBC is 30,000. Okay? So this is leukocytosis. Then you have neutrophils 60%, lymphocytes 10%, eosinophils 7%, monocytes 3%. And these are cells which are the immature myeloid cells. Myelocyte 4%, metamyelocyte 7%, band forms 9%. So when you see that the differential count also has immature myeloid cells, this is known as shift to left. Okay. So in a peripheral blood smear, if we also count immature cells, that means it is shift to left. And shift to left basically means that the bone marrow is over-proliferating and it is pushing these immature cells out into the blood. So maybe there is some source of infection and the bone marrow, the body feels that it is not getting enough of neutrophils or myeloid cells to fight that infection. And it gives the indication to the bone marrow to proliferate much more. The bone marrow starts to proliferate much more and pushes out the immature cells. They don't allow the neutrophils to mature because they need time for the neutrophils to mature. In this case, because they have to fight the infection in the periphery and there's no time, so the bone marrow starts to bring out the immature cells also. They get into the peripheral blood. So this is known as shift to left. Okay. So here the hemoglobin is normal. The platelet is normal, but WBC there is leukocytosis, and looking at the differential count, there is shift to left. Okay, so this is leukocytosis with shift to left. The next one, and this is basically a kind of, you can say it's a leukemoid reaction, which I had shown you, I think, yesterday. I had shown you leukemoid reaction versus leukemia. In this case, there are no blasts, so obviously it's not a leukemia, okay? But because the count is very high, 30,000, and because there is a shift to left, so this can also be called a leukemoid reaction, okay? The next question, 25-year-old lady, acute cholecystitis again, the hemoglobin is 12, which is okay. WBC is 30,000, same like the previous one. Everything is same like the previous one. So there is leukemoid reaction. The only thing I've added here is the peripheral blood smear also shows nucleated RBCs. 5 per 100 WBCs. Nucleated RBCs are basically immature RBCs. So again, like I said, the bone marrow cannot wait. It's proliferating, and when the bone marrow proliferates, usually all the 3 cell lines proliferate. That means the erythroid also proliferates, the myeloid also proliferates, and the megakaryocytes also proliferate in a normal person with a normal bone marrow. Okay, I'm not talking about other conditions which are pathological. In a normal person, when there is severe infection, the bone marrow is normal, it will become hypercellular because of the proliferation, and the proliferation is usually of all the 3 lines. So in this case, the RBCs, immature RBCs, which still retain their nucleus, they get thrown into the peripheral blood, and we see them in the peripheral blood. So when we see nucleated RBCs along with this picture of a leukemoid reaction, this is known as a leukoerythroblastic picture. Okay, so when you get a leukoerythroblastic picture, it starts to be a little bit sinister. As a clinician, when you get a picture like this, if you get a picture like number 5, I said is a leukemoid reaction, you have a reason for the leukemoid reaction. The lady is presenting with acute cholecystitis, severe acute cholecystitis. So you have a reason for the leukemoid reaction. You have a reason for the bone marrow to proliferate. So you will not investigate further. However, if the same lady comes with acute cholecystitis and she has this leukemoid reaction, but she also shows nucleated RBCs in the peripheral blood, and it becomes a leukoerythroblastic reaction. In that case, as a clinician, you should know that leukoerythroblastic reaction requires the bone marrow to be examined. Okay, because only in pathological cases, the nucleated RBCs actually get pushed into the peripheral blood. It's usually shift to left with leukocytosis is known in infections, but nucleated RBCs usually do not come in the peripheral blood unless there might be something sinister in the bone marrow. So this case will require a bone marrow examination. Okay, so when you see this kind of a picture and the pathologist writes leukoerythroblastic reaction, usually as pathologists we advise the clinicians to do a bone marrow if clinically indicated. Okay, number 7, this is a 35-year-old male. There is moderate splenomegaly. So this starts to become really pathological. Spleen is increased only in pathological conditions. Okay, so you have a 35-year-old male with moderate splenomegaly. Hemoglobin is 12. So for a 35-year-old, the hemoglobin is on the lower side. 12 is anemic. The WBC is 58,000. That means this is definitely leukocytosis. Then look at the differential. The differential here, you can see neutrophils are 46%, lymphocytes 6%, eosinophils are 9%, borderline eosinophilia is there. Basophils are 3%. Basophils are cells which you usually do not see in the peripheral blood. If you see by fluke one basophil and you count the cells, it will be less than 1%. But here you are getting 3% basophils. That means there is basophilia. Okay, so you have leukocytosis, you have eosinophilia, you have basophilia, and monocytes are okay. Promyelocytes are 2. These are really immature cells. Okay, myelocytes are 18%, metamyelocytes 11%, band forms are 2%. Okay, so when you look at this differential, you can see that there is shift to left. But along with the shift to left, there is also eosinophilia and basophilia. And if you go back to the clinical details, the man has splenomegaly. Okay, so that sounds very pathological. Platelets, 5.9 lakhs means it is increased. And also the nucleated RBCs have come in the peripheral blood, 7 per 100 WBC. So this kind of a picture on the peripheral blood itself, if you study these counts, you will know that you're dealing with a neoplastic condition. And the only neoplastic condition which will have splenomegaly with leukocytosis, with a lot of shift to left, with eosinophilia and basophilia and platelets being high, and there may be nucleated RBCs, this is definitely a chronic myeloid leukemia. We are not calling it acute leukemia because there are no blasts here. Okay, there are no blasts. So this is a chronic myeloid leukemia. Okay, and if you look at the next question, number 8, I am giving you a very similar question. The only difference here is the hemoglobin is quite okay, borderline for a 35-year-old, not really anemic. The WBC count is, there is leukocytosis, but not as high as the previous one. And if you look at the differential count, there is shift to left. Okay, but eosinophils are 9, which is borderline, but there is no basophilia. See the difference? There is no basophilia. Okay, and platelets are very, very high, 9.9 lakhs. And the peripheral blood shows clumps and giant platelets. So when you see a picture like this, again you will think of a myeloproliferative neoplasm because you are getting proliferation of WBC, you are getting proliferation of the platelets, and the platelets are really proliferating markedly. There is shift to left, but there is no basophilia, there is splenomegaly. So when you look at these, you have to think along lines of one of those MPNs. So we have discussed chronic myeloid leukemia here. I have told you the points, especially basophilia is very important in chronic myeloid leukemia. Here, because the platelets are very, very high, you have to think of a condition in which the platelets are the ones which are pathological, that is known as essential thrombocythemia. Okay, so you have this this case. These are all syndromes which may overlap. Okay, when you talk about myeloproliferative neoplasms, the findings may overlap, but you have to look for something which stands out, and you have to always have in mind all the 3 or 4 conditions in your mind, myeloproliferative neoplasms, then you will know what is the difference. So in chronic myeloid leukemia, the proliferating cells are the WBCs, okay, and eosinophilia, basophilia with shift to left. In essential thrombocythemia, there will be leukocytosis, there will be shift to left, but there is no basophilia usually. Eosinophilia is also not common, but the platelets, the counts will be very high and there will be huge clumps of platelets in the peripheral blood. And of course, splenomegaly will be there in both. Again, another one which is very similar, again, 35-year-old moderate splenomegaly, hemoglobin is 19 grams. So this is definitely a high hemoglobin. RBC is 7.8 million, very high RBC count. WBC is 21,000, again leukocytosis. So looking at this, you know that you're dealing with a proliferative neoplasm. There is a shift to left, again the same kind of a differential here. There is shift to left, but you can see the shift to left in chronic myeloid leukemia. Promyelocytes, more mature cells are there, and myelocytes are 18%. But look at what I have done in essential thrombocythemia and okay, in thrombocythemia, the promyelocytes are 2%, but myelocytes are 8%. In this case also, the myelocyte and metamyelocyte are lesser than the CML. Okay, so this is important for you to notice here. The main thing is the hemoglobin is very high and the RBC count is very high. Platelets are on the proliferative side, 4.9 lakhs is just borderline high. So here you know that you're dealing with a myeloproliferative neoplasm and probably it is polycythemia vera. Okay, so in CML, the genetics you have to do to confirm this. If we give this in peripheral blood, you have to do a bone marrow, all 3 of them. Bone marrow needs to be done and genetic studies need to be done. So for CML, we look for BCR-ABL. We order a genetic analysis to look for BCR-ABL. If it is positive, we are confident it is CML. Another thing in CML is you have to know the phase of the disease. So when you look at this, the hemoglobin is borderline low. This is high. There is shift to left, but there is no blast. Okay. So in this case, this is a chronic phase. Had the blast been 5% or like within 5% is chronic phase. If it's 5 to 19%, we call it accelerated phase. And if it is more than 20%, it is blast crisis. Okay, so you have to know the phase also. So questions which may come here is which phase this patient is in. Okay, which phase of the disease is this patient in? That kind of question can come, and you have to answer that as this is chronic myeloid leukemia in the chronic phase. Okay. Then this is polycythemia vera. So for genetic studies of essential thrombocythemia and polycythemia vera, both of them will show that, I've forgotten. Oh, it's okay, you look up in those PPTs which I have sent you. Then number 10 is a 58-year-old male with massive splenomegaly. See the difference here. I have given you relatively the same age group in MPN, whereas for this, I increased the age group significantly. This is an older age group, 58-year-old male. And the size of the spleen also, massive splenomegaly. So there are very few disorders which have massive splenomegaly. So like I have said, the myelofibrosis, hairy cell leukemia, chronic myeloid leukemia may present with massive splenomegaly, especially in the blast crisis phase. Okay, so here you have a 58-year-old male with massive spleen. Hemoglobin is 11 grams, which is on the lower side. RBC is 3.8 million, normal. WBC is 21,000, proliferating. Leukocytosis is there. Look at the differential. There is shift to left. Platelets are 2.9, which seems okay. And peripheral blood smear shows teardrop RBCs. So when you get teardrop RBCs, you know that you're probably dealing with this history, with this massive splenomegaly. You know that you're probably dealing with a myelofibrosis. Okay, and like I said, myelofibrosis can be primary or it can be secondary. So all of these three, CML, ET and PV, all three are, along with myelofibrosis, are myeloproliferative disorders, and all these three can go on to develop secondary myelofibrosis. Okay, and this myelofibrosis is the primary myelofibrosis. So again, genetic studies is required to be done here. Okay, so teardrop RBCs are a very important indicator to indicate that there is fibrosis of the bone marrow. So obviously in all these 4 cases, the next step is to do a bone marrow aspiration and also a biopsy. The advantage of doing a biopsy is that you get to see the architecture of the bone marrow, and very importantly, you do special stain to assess the fibrosis. Okay, so you need to assess the fibrosis. You have to do a biopsy of the bone marrow. Otherwise, you cannot do it on an aspirate. Aspirate is cytology. Okay, we can study just the cells. But in biopsy, you can actually do special stains. And if it is in blast crisis, you need to find out what type of blast crisis it is. Because in chronic myeloid leukemia with blast crisis, if the blast cells are myeloblasts, the treatment is like acute myeloid leukemia. If the blast cells are lymphoblasts, the treatment will be like acute lymphoid leukemia. So remember, whatever is being done is basically to get to what therapy is necessary for this patient. So whatever information we can get from samples, genetic studies, and also the flow cytometry, the immunohistochemistry, the markers which we get, everything will get us closer to what are those cells actually, so that we know that which therapy is required for those patients. Okay, so that is known as targeted therapy. And you know very well that in chronic myeloid leukemia, BCR-ABL is basically a tyrosine kinase inhibitor. So we give tyrosine kinase inhibitor drugs, okay, which controls the chronic myeloid leukemia. And chronic myeloid leukemia patients can go on to live for another 20, 25, 20, 30 years also, provided they are responding to the treatment. Of course, nowadays there are some cases which are resistant, but most of them do respond to treatment. Okay, now coming to 11. This is a 65-year-old male, mild hepatosplenomegaly, persistent anemia after treatment past 6 months with hematinix. The hemoglobin is only 5.8. The WBC is 9,000, which appears okay. The differential appears all right. The peripheral blood smear shows hyposegmented neutrophils, Pelger-Hughes cells, and platelets are 1.2 lakhs. So when you look at this, first thing you should notice is it's an older gentleman, 65-year-old, and he has got organomegaly, definitely pathological, and the anemia has been there past 6 months. Despite being treated with hematinix, his anemia is not responding. So looking at this history, you know very well that it is pathological. And very important is persistent anemia after treatment. This history is usually in myelodysplastic syndrome. Usually you get this history in cases of MDS. MDS is a disease which usually occurs in older age group. So looking, the hemoglobin is very low. This is okay. And the peripheral blood smear shows hyposegmented neutrophils, which are the Pelger-Hue cells. These are definitely dyspoietic myeloid cells. So, and the platelets are 1.2 lakhs, which is on the lower side of normal. So this is a case of myelodysplastic syndrome or MDS. Okay, number 12. Okay, so number 12 is a 4-year-old boy with moderate hepatosplenomegaly. Okay, so it's a child with organomegaly. Hemoglobin is 7 grams, so anemia is there. WBC is 90,000. That means there is leukocytosis, and this is very, very severe leukocytosis. Blasts are 80% and lymphocytes are 20%. So looking at this only, you know you're dealing with acute leukemia. Platelets are 45,000. That means there is thrombocytopenia, which is known in acute leukemia. And peripheral blood smear showed blasts with scant cytoplasm and condensed chromatin. So this sort of a history of a child with organomegaly, with anemia, with leukocytosis, differential is blasts 80%, and thrombocytopenia, and peripheral blood shows blasts with condensed chromatin. This is a classical history for acute lymphoid leukemia or acute lymphoblastic leukemia. Okay, so even if I give here blast 20%, it is enough for you to say acute leukemia. When the blast is 20% or more, then we call it acute leukemia. In this case, I am calling it acute lymphoblastic leukemia because of the morphology of the cells, that the blasts have scant cytoplasm with condensed chromatin. However, it is not enough on a peripheral blood to diagnose acute lymphoblastic leukemia and expect the clinician to start treatment. It is never like that. After that, we ask for more. We ask for bone marrow aspirate. And on the peripheral blood, if the count is very high, like here, the count is 90,000, the blasts are 80%. So we know that the cells of interest are the blasts. There are enough of blasts. We can take the peripheral blood and do a flow cytometry. And we can put all sorts of markers on it to confirm that they are lymphoid. And it is not enough for us to say acute lymphoblastic leukemia. You have to say whether those lymphoid cells are T cells or whether they are B cells. So if CD3 is positive, it is T cell. If CD19 is positive, it is B cell. So this is important because TALL is different. The therapy for TALL is different from a BALL. The prognosis for TALL is different from BALL. So as pathologists, we have to give the clinical diagnosis. We have to actually put the markers on flow cytometry and say whether they are the T cells or whether they are the B cells, okay? Because the treatment is different for each. Now coming to 13, 21-year-old boy, moderate hepatosplenomegaly, hemoglobin is very low, 4 grams. WBC is 1 lakh, very, very high. Blasts are 89%, so very high again. So looking at this, immediately it will click that it's acute leukemia, okay? Now platelets are 35,000, there is thrombocytopenia. Peripheral blood shows blasts with fine chromatin, nucleoli, and R-rods. Once you get R-rods in the blast, you have no doubt that this is acute myeloid leukemia. If I had not put R-rods, if this question did not have R-rods on peripheral blood smear, we wouldn't be able to say directly that it's an acute myeloid leukemia. We can just say it's acute leukemia, and we have to ask for the blood sample to run the flow cytometry, to run the markers, and to confirm. And one thing which is very, very important about acute myeloid leukemia, yesterday I showed you a picture that the myeloid stem cell is the one which gives rise to the myeloid cells, also the erythroid, and also the megakaryocytes. So there are so many types of myeloid leukemias. But the type which matters to the therapy is only the AML M3. Okay, AML-M3 is an acute promyelocytic leukemia. So this is important because it has got a very different genetics behind it. Okay, so I think the translocation 1517, if I'm not mistaken, please check it up. AML-M3, the genetics is very important, and there is targeted therapy for this. Just like CML, BCR-ABL is a tyrosine kinase inhibitor, and there is targeted therapy. In AML-M3, the genetics is very, very specific, and the therapy is very specific. So when we do flow cytometry, we just want to know whether this acute myeloid leukemia is M3 or whether it is non-M3. It doesn't really matter if we say it is erythroblast or whether it's megakaryoblast, okay? It doesn't really matter. What matters is if the acute myeloid leukemia is M3, that means is it acute promyelocytic leukemia, or is it non-M3, that means it is not APML, okay? Because the treatment for APML is very, very specific. They give retinoic acid or something like that, okay? So there is a specific genetic translocation in AML-M3, and there is a specific therapy for that, okay? So that is important. Now, 68-year-old male, health checkup, see this, health checkup, that means he was not symptomatic at all. But on examination, there is generalized lymphadenopathy, mild hepatosplenomegaly, which the person didn't even know. Note the age, 68-year-old, so it means it's an old man, and hemoglobin is okay, WBC is raised, and look at this, lymphocytes are 88%, and peripheral blood smear shows smudge cells. Yesterday, I showed you a picture of lymphoid cells, and those lymphoid cells, I said they are very fragile, so when you make the peripheral blood, they burst and they form smudge cells. So this is a classical history for a chronic lymphocytic leukemia, okay? Usually they are asymptomatic, but they will definitely have tissue infiltration into the lymph nodes and the organs. 65-year-old, the next one, 65-year-old, presents with backache. So look at this, again, an old person, 65, with backache. Hemoglobin is low, there is anemia, WBC is okay, platelet is okay, but the peripheral blood smear shows Rouleau formation and chest x-ray shows lytic lesions on the ribs. This is again a classical history for a plasma cell neoplasm or a multiple myeloma. And multiple myeloma, please read it up, it is important. Rouleau formation is basically because the IgM protein is so high in the serum, it acts as a sticky glue, so the RBCs get stuck to each other. That's why in the peripheral blood smear we get Rouleau formation. Okay, so this is multiple myeloma. Then 16, this I have not sent to you, but I just made it up in the last minute. 21-year-old lady, hemoglobin is 11, which is a bit low. WBC is very, very low, 800 only. And you'll see here neutrophil is only 2%, lymphocyte is 98%, platelets are 1.5 lakhs, which is normal. So if you look at this, she has got leukopenia, right? The total count is very low, leukopenia. And when you look at this, you know that she's got neutropenia as well. Okay, now you have to decide whether this is just neutropenia or whether it is agranulocytosis. And to do that, you have to calculate the absolute neutrophil count. So you take the total count and take the differential count and calculate the absolute neutrophil count. If the absolute neutrophil count is around 500 or less than that, it is neutropenia. If it is only 100 or less than that, it is agranulocytosis. This is important for practical purposes for you in your clinics. In pathology itself, I don't remember asking questions on neutropenia and agranulocytosis, but this is nice for you to know. Okay, so I hope you're following that. The last one, 12-year-old boy, hemoglobin is only 3 grams. Very, very low, there is anemia. WBC is only 1,000, there is leukopenia, and platelets are 20,000, so there is thrombocytopenia. So 3 of the penias makes it pancytopenia. Okay, so 12-year-old boy with pancytopenia, neutrophil is 5, lymphocytes are 95. When you see this kind of a differential, you can think of only one thing in a 12-year-old boy, and that is aplastic anemia. And the next thing you should go forward to confirm this is to do a bone marrow aspiration. In aplastic anemia, bone marrow aspiration may yield a dry tap because there are hardly any cells in the bone marrow. You might just pull out only air. Okay, so these are the conditions in which we require to do a bone marrow biopsy to check for the cellularity of the bone marrow. So this is a case of pancytopenia, probably an aplastic anemia. Okay, so I hope this has been useful to you. And the questions which may come in pathology, this aplastic anemia is important, multiple myeloma, chronic lymphoid leukemia, then AML, ALL, then this is what? MDS, we usually do not ask MDS. Then from these, CML is the most important. Okay, from the MPNs, CML is the most important. Some objective questions may come from this, the genetics also. Okay, and then all these leukemoid reaction versus chronic myeloid leukemia, some of the points which I've told you in the table that day. And that's it, I think. Those are the most important as far as pathology is concerned. And I forgot to send the PPT yesterday, so I have mailed it today. You can go through the revision PPT for WBC disorders. The next class will be on Monday. It will be taken by Biswajit on Dr. Biswajit on respiratory system revision. Okay, thank you.